Welcome everyone to our regular Lunch and Learn. I am on the board. My name is Joanna, and I'm on the board of our local NAMI affiliate here in Johnson County. And every month we have these wonderful presentations. And today we're going to be talking about cognitive behavioral social skills training for schizophrenia spectrum disorders. And joining us to do this presentation are Tess Filip and James Lopez. Tess is a third-year student, and James is a second-year student in the clinical psychology PhD program at the University of Iowa. So I'll let them take it away and tell us more about this. Thank you.
Yeah, thank you so much for introducing ourselves. So just to recap, I am a graduate student. My research is mostly focused on the use of digital tools, how we can see symptoms kind of as they happen, as people go about their daily lives, and different environmental factors that might influence functioning in people with SMI.
Hi, I'm James. I'm a second-year student in the clinical psychology PhD program, so in the same lab as Tess. In my research, I'm really interested in kind of early perceptual processes, so measuring that using tools like EEG, so put a fun cap on people's heads, put some goop in their hair, look at kind of brain activity and seeing how that relates to kind of cognitive tests that we do and how those relate to overall functioning in people with severe mental illness.
And we just want to say thank you all for joining and listening to us today. We're really excited to talk about CBSST, which is a new therapy we're hoping to start up here in Iowa City. So before we begin talking about what is CBSST, what are we offering, I wanted to just start to talk a little bit about the prevalence of severe mental illness, also called SMI. So we can see in this graph here, this is the prevalence of SMI among adults in the US. So we can see it's about 5% overall, a little bit higher for females and for those who are 18 to 25, and then higher also among those who identify as Alaskan Native, American Indian, or 2 or more races. So we can see because it impacts a large part of the population, these things really matter, that we have treatments that can help severe mental illness. But today we're talking about psychotic disorders, which makes up even less of the population with a lifetime prevalence of about 3%. And schizophrenia in particular is estimated to have a prevalence of even smaller, around 1%. So although schizophrenia is relatively rare, it's in the top 15 leading causes of disability worldwide, which really demonstrates that it has a really significant impact and burden. So altogether, this points to the real need for effective treatment options, which we are presenting to you guys today. So what makes up a diagnosis of schizophrenia? So you guys in the audience may already know this information, but just to kind of review some of it. So we use what's called a diagnostic manual to classify people as having a disorder or not. And in that diagnostic manual, if people have 2 or more of the following symptoms, they may have schizophrenia. So they may experience delusions, and delusions are fully believing in something, even when presented with evidence that it may not be true. So sometimes this can look like thinking that people are following you, thinking that people want to hurt you, those sorts of thoughts. People may also experience hallucinations. So that may look like seeing things or hearing things that don't exist. And hallucinations can actually occur on all 5 senses. So it can also be like feeling things or tasting things that don't exist as well. People with schizophrenia may have disorganized speech. So that can look a lot like speech that kind of veers off track, and maybe in more severe cases, it may be kind of strings of words put together that don't make a whole lot of like logical sense. And schizophrenia also sometimes comes with negative symptoms. So it's kind of a group of a bunch of different symptoms, all called negative symptoms. And that can look like a loss of motivation, so not feeling the motivation to kind of get up and engage in everyday things, even things like taking a shower, brushing your teeth may be really difficult. It can also look like a loss of enjoyment or pleasure in things that maybe they would normally enjoy. It can look like a loss of interest in engaging in social conversations or kind of maintaining friendships, just social relationships. And it can also sometimes present as like a lack of speech. So just not a lot of kind of speech kind of coming out, like one-word responses. And also, some people may have difficulty actually expressing emotions on their face. So, normally when we smile, we kind of like have the wrinkle lines near our eyes. So someone with schizophrenia may be feeling happy, but that might not be actually expressed on their face. So overall, people with schizophrenia can have sort of any different combination of these symptoms, but the main sort of takeaway is that these symptoms can be really, really impairing in people's functioning. So that can be functioning at work, at school, with their friends, and it may be so great that it impacts in the ability of someone to actually take care of themselves. So overall, kind of the symptoms of schizophrenia broken down into more simpler terms. Schizophrenia can be expressed as trouble with thoughts, with perceptions, and communication that may significantly impact both the person with schizophrenia and sort of their interactions with others and the world around them. So what do we know about what works?
Yeah, thanks for the great overview of the different symptoms and experiences people may have. So I kind of want to just pose a question to everyone in the audience to write in the chat or unmute yourself. But what are your thoughts on kind of potential treatment options for severe mental illness and schizophrenia? Like first line defense, what comes to mind? Cool. Yeah, I'm seeing some responses in the chat. Thank you, everybody. All right. Yeah. So I'm seeing medication, therapy. Awesome. Yeah. So that's all I was hoping to hit on. So, yeah. So there are different kind of pharmacological interventions like medication. And medication has shown to have really positive outcomes on targeting symptoms such as like delusions and hallucinations that Tess mentioned previously. And we also have some really great options in therapy. So psychosocial interventions, just to name a few, things like assertive community treatment. So this is really intensive and highly integrative approach of a community mental health setting to make sure people have all the resources to get to different appointments, really working with people one-on-one to facilitate different goals and kind of things like that. But unfortunately, that isn't always available throughout the community. Things like behavioral family therapy also is a really great option, really emphasizing kind of the strengthening of family support systems through things like psychoeducation, communication skills training, and things like that. And social skills training, or SST, really working on kind of communication skills, working with people, it may be a family member, a friend, or even kind of physicians, really working on that dialogue. And also cognitive behavioral therapy, or CBT. And You may notice that our presentation, CBSST, wants to pull from both these aspects that we have seen are really effective and wonderful options, and how do we kind of improve from there. So before the next slide, what are your guys' thoughts on, so we have some really great options and treatments that work. What do you guys think are kind of the gaps? What's missing? How do we make these treatments more effective? Yeah, I'm seeing access, kind of skills, community support, things like that. Cool. Yeah, so how do we integrate all these things moving forward? Awesome. Yeah, you guys are really hitting on it. So this is kind of pointing towards like a multi-tiered process of recovery, and the gaps that we see from kind of the evidence and the research, kind of what we know and how do we kind of transition that into the practices throughout our community. So just for an example, we know that kind of these pharmacological treatments for schizophrenia are really great at improving kind of symptoms such as delusions and hallucinations, but that really highlights it's only one kind of aspect of recovery. There are also things like motivation, beliefs, those negative symptoms that Tess talked about before. And again, kind of with access, we have these really great psychosocial interventions, teaching skills, but access might be limited. There might not be clinicians with years of training or oversight available. We know that there are also kind of long wait times and things like that. So we're really excited about CBSST and to talk about it more. So how do we translate kind of what we know from the research, and how can we better integrate it into our community, which we are, really excited to share today.
Alrighty, so we're talking about CBSST. So again, that stands for Cognitive Behavioral Social Skills Training. And this is new to Iowa, but not necessarily new. Therapeutic intervention that we're now offering to people who are living in Iowa, but able to kind of come to Iowa City. So James will talk a little bit about the evidence for CBSST, but suffice it to say, it is an evidence-based treatment, and it really focuses more on recovery goals and psychosocial rehabilitation, kind of as opposed to that symptom reduction approach that medication kind of handles decently well. So the overarching goal of CBSST is to increase motivation and sort of self-efficacy among people with schizophrenia, to increase social engagement and kind of get out there in the real world and practice real life applicable skills that are specific to whatever goals they come in with that they want to work on. So CBSST, like I mentioned, has a good deal of evidence supporting it in different research trials that have gone on. And it works really well for people with schizophrenia to live more independent lives. So James mentioned, but CBSST is made up of two different types of therapies that are kind of already out there. So the first is what we call CBT, or cognitive behavioral therapy. And CBT is aimed at really working through these sorts of negative thoughts that we all have, that all come up. And those sorts of negative thoughts can sometimes get in the way of different treatment goals. So as an example, that could look like, why should I even go to therapy when it's never going to work because nothing kind of works for me? And we'll talk a little bit more about what those look like. But it also contains SST, which is social skills training. And so that's where people in the group can come and practice new skills in the session. And that may help with social engagement outside of session in their real lives. So these are the two parts that make up CBSST, and we'll go into some detail about it. And we're trying to give you a sense of what the actual therapy would look like if you were sitting in on one of the sessions. So before we kind of go into that, I just want to talk about what we believe to be the essential sort of ingredient to CBSST. And that's the idea that we're working through both identifying and then challenging what we call defeatist beliefs. So what are defeatist beliefs? Defeatist beliefs are these ideas that we all hold about ourselves that sometimes hold us back from going out there and trying new things. So it can look different for everyone. So these are just some kind of like standard examples. But it could be like, if I don't do something perfectly, that means I'm a failure. It can look like, for me, giving this talk, why should I even give this talk today when I'm just going to sound dumb? And then maybe more for people with schizophrenia, it can look like, even though I take medications, I still hear voices. That must mean that I'm never going to get better. So the idea behind CBSST is if we fully believe in these thoughts and we will believe we will fail before we even start something, we probably won't be very motivated to actually go out there and do whatever it is, right? So we have this kind of narrative going in our minds. So the idea is to identify these beliefs and then challenge them by thinking, what is sort of the evidence for this thought? What is not the evidence? You know, maybe this thought is not going to drag me around as much as I let it before. So people can work towards their recovery goals and increase motivation to get out there. So overall, these are defeatist beliefs and what we think of as kind of the core process by which CBSST is helping people. And that leads us nicely into the first kind of module of CBSST, which is working through these negative thoughts. So for the overall structure of what it looks like, there's 3 modules, and each module has 6 sessions. So that's 18 sessions total of the whole kind of therapy program. So first, the therapy is structured to work on cognition, or also what we just call thinking skills. And the idea is to be able to create, again, a little bit of distance from those negative thoughts by catching it, or it's part of the 3 C's, which is kind of just a fun acronym to check out those thoughts. And then we check it out. So that thought is saying, you know, I'm going to sound dumb when I give this presentation. And then the last part involves changing that negative thought into something more positive. So I could sound dumb, but I also could do just fine at this presentation, and people can learn new things. So the goal of the cognitive skills module is to, again, target those automatic defeatist beliefs, break down the evidence for those thoughts, and build up motivation. The second module is the social skills module, and that involves a lot of different role plays to practice different communication skills. And then the final module is the problem solving module. And that involves breaking down a goal into really small, tangible steps, developing a really specific plan, acting on that plan, and then evaluating, did that go well? Did it not go well? What sort of barriers came up? And all throughout the sessions, we work through goals that people bring to therapy. So it's specific to them. It can look like, how do I make new friends? How do I find a job? Sort of any goal that the client identifies that is like a reasonable short-term and long-term goal.
All right. So now we're going to kind of go into kind of the more specifics of what this may look like in this group. So, for example, here is something called the CBT triangle. And kind of the idea behind this is that our thoughts, feelings, and behaviors are all related. So on this slide, I thought we could go through it just together. So imagine we have the thought, can you click ahead one
Sorry.
second? Yeah, no worries. Imagine we have the thought, nobody likes me. What are some potential feelings that might come up if we have that thought? Cool. Yeah, I'm seeing we might be sad, we might be angry, frustrated, upset, hopeless. Yeah, definitely. So any of those would fit in that box. So our feelings are going to be related to the thoughts that we're having. So what do we think kind of if we're feeling upset, frustrated, hopeless, what types of behaviors would that kind of translate to? Or what maybe will we do or not do? Yeah, I'm seeing isolate, stay home, avoid. Yeah, awesome. So some behaviors, yeah, we might stay home, we might not do anything, reducing kind of our activities. And then this kind of, again, just is feeding into that cycle of if we're not engaging in different activities, then we might have more kind of negative thoughts of nobody likes me, again, kind of feelings of being upset. Um, so again, the idea of CBSST is really targeting those negative thoughts and defeatist beliefs to really get us engaged in more activities instead of limiting ourselves from the start. So this next slide is just some a list of some kind of thinking traps or unhelpful thinking styles that we all have had at some point. So this is not an exhaustive list, but we may have thoughts that are all or none, basically. So something's either all good or all bad. There isn't really a gray area. Things like jumping to conclusions, so little or no evidence, or thinking of kind of the worst possible outcome, catastrophizing. This can also look like mind reading. So we might say, um, you know, I'm giving this talk. I know people think like this is boring without kind of any evidence to back that up, or fortune telling, so predicting the future. I know I'll mess up on X. Some emotional reasoning examples. So I might feel anxious during this talk, but that might make me think that I'm not doing a good job or something like that. So all of these are just to say like these thinking traps are normal for everyone to have. They're very common, and it's not just limited to people and with severe mental illness. But we're hoping to kind of work with these negative thoughts first, catch them, and how do we best kind of be flexible with these thoughts that may come up. And how do we do this? The whole goal of kind of this program, we want to make it as fun and kind of collaborative as possible. So identifying these mistakes in thinking through these modules using the 3 C's of catch it, check it, and change it. One example could be having kind of like a red flag in our group. So we might present some examples, say them out loud of, I'm not good enough for X. So we may, during the session, we might all have red flags, just as kind of a really salient technique of how do we catch these thoughts when they come up, identifying, was this an unhelpful thought? And is this thought helping me reach a goal, or is it kind of hindering me? So once we're able to identify and catch that thought, we like to check it out. We can look at it like a detective, see what is the evidence for that thought. Is this a mistake in thinking? And the ultimate goal is to kind of change it and develop a more helpful thought by using different experiments to see if it is accurate or not, with the overall goal to reduce kind of that certainty of harmful beliefs that we may have that limit us from even engaging in activities that we might want to.
Alrighty, so James gave a great overview on the cognitive skills module. So the second module in CBSST is the social skills module. And it's kind of what it sounds like. So it's focused on developing and applying applicable skills that people can do in the session, but also in their real lives. And we focus heavily on role plays for this. And that can be role plays on communicating with people around you, so family members, friends, roommates, treatment providers as well. So one skill that we practice in the group is expressing both positive and negative emotions, and also making a positive request or asking other people for help. So this can look like practicing the phrase, when you do blank, I feel Y. So for example, when you interrupt me, I feel sad or I feel upset. So again, kind of the goal of this module is to improve that everyday social functioning component, which can sometimes be impaired in people with schizophrenia. And some other role plays that we might bring up in the session might involve very specific sort of interpersonal challenges that are going on in the client's life, and role playing how to work through that with the other person. So if someone has hurt your feelings or made you upset, for example, say you live kind of in a group setting home and your roommate steals your food, we might practice how to approach that situation in a firm but non sort of like argumentative way. At the same time, we also practice sort of nonverbal behavior, so making eye contact, speaking with a firm but gentle voice, loud enough so that other people can hear. Same thing as if I were to give this presentation, facing this way, it wouldn't probably be as effective as if I'm looking at the screen. So those are things we kind of practice over and over again. So people kind of pick them up and can apply them in the real world. And what we know from research is that although clients may master these skills in therapy, so they're doing all of this great, when they're there in session, but they may not go out there and actually practice them in the real world. And part of the reason might be because people are having these negative thoughts. Like, if I tell someone how I feel, they're going to think I'm stupid, they might fight me, XYZ sort of thing. And so that's really the motivation for why we combine that cognitive model with this social skills training module. So we not only develop these skills, but try to break down the barriers which cause people to not actually go out and practice these things. So lastly is the problem-solving module. And this works with individuals to, again, identify goals that they have, that they want to work towards, and really break that down into the smallest kind of steps possible to reach those goals. For this module, we use this acronym, kind of sets the tone for what the sessions are about, but it's called SCALE. So it stands for specify the problem, consider all possible solutions, assess what is the best possible solution, lay out a plan, a really specific plan, execute, so go ahead and do it, and evaluate, did that work? Did it not work? What got in the way? So different goals that can come up. It can look like, how do I find a job listing? How do I take a bus downtown? How do I develop a budget? It can also look more like treatment goals. So how do I remember to take my medications every day? How do I find a partner? Really, sort of anything is possible. So one exercise that we actually do in the group is to practice coming up with possible solutions and to consider any possible solution, no matter how silly, how ridiculous, or impossible that it may sound. Because again, we're trying to not let our mind filter with like, oh, that's a dumb idea. We want to kind of just get it all out there. So I thought we could do this exercise together. I'll have you guys type in the chat for this one or unmute yourselves, whatever you feel more comfortable with. So say the problem that I have is that my cat is stuck in a tree. I want you guys to try to think of 30 or just a bunch of different ways that we could get the cat out of the tree without censoring, like no matter how ridiculous it may sound. So people are saying you could climb up and get it. You can call animal control or a fireman. Shake a treat bag at the bottom of the tree. 2 shaking bags of treats at the bottom of the tree. Call a friend or neighbor. Do some cat calls, like try to speak cat language to, get them to come down. Spray some water on the cat to get them to jump off. Open a can of high roller cat food, or you could chop down the tree. All right. Yeah, these are great suggestions. So you can see some of them may not be as realistic. You could chop down the tree. It just might, the city might get mad at you for chopping down like a nice oak tree or something like that. So the idea behind the module is really just putting everything out there, being really creative, and then going back later on to kind of identify which method might actually be the most feasible. After we work through coming up with the most feasible solution, we would lay out a plan to going ahead and doing that. And that would be like, on Monday at 2 p.m., I'm going to call animal control to get the cat out of the tree. We would go ahead and do that at Monday at 2 p.m. And then we'd come back to the next session and evaluate how that actually went. And if in the future, maybe we need to kind of take a different approach or not.
Awesome. Yeah, so just briefly, just to give some evidence of the efficacy of CBSST, I won't bombard you with all the kind of randomized control trials, but I'm happy to kind of talk about that a little bit more if you have questions about what's been done. But kind of the main take-home message through these different trials is that while engaging in CBSST, we see kind of improved outcomes for functioning, those decreases in defeatist attitudes, which is a real kind of goal of targeting those negative kind of cognitive thought patterns that we may have. And overall, just large meaningful effects for those negative symptoms that we talked about at the beginning. So kind of reduced motivation or kind of loss of interest in things that you may have used to enjoy. So this has been shown across kind of a wide age range from older adults, kind of younger adults, but happy to talk about that a little bit more. But a really exciting thing and like really an advantage of CBSST is that it's been shown to be effective from people that aren't professionally credentialed mental health care providers with many years of clinical experience. It's been shown to be effective when it's delivered by peer specialists, so people that have gone through the program with lived SMI experience. It's been kind of deployed with really good fidelity. So this is really exciting of reducing that barrier of how do we kind of get these into the community? How do we work with community members through this process? So we're really excited about doing this at Iowa, and we'll talk a little bit more about that next.
Alrighty, so James mentioned there's plenty of evidence to suggest that CBSST is an effective method of helping people with schizophrenia live kind of more happier, more fulfilling lives. Some other benefits of CBSST, the modules are all designed to be experiential, meaning everyone in the group will learn by actually doing these things. So it's not just us talking about what are these things, but actually going around and people practicing everything. So with me and James, but also among themselves in the group. And that's really because we're some point teaching skills, and we know that doing skills over and over again is what helps them get better, right? Like the first time you pick up a guitar, you may not be very good, but the more you practice it, the better you'll become. So we also try to design the modules to be fun and interactive. James kind of gave some examples of the different props that we may use, like waving a red flag. There's like a ball tossing game, coming up with like silly ideas of like getting the cat out of the tree. And so it's all kind of aimed at making people feel comfortable and getting people out of their comfort zone, and giving them sort of a chance to practice these new things, even if, we might make mistakes, which James and I will inevitably as well during the session. It's also a chance for people to meet each other. So I saw in the beginning, a lot of people were mentioning just having community support. So talking with others who also experience SMI can be really helpful. We know that sometimes living with schizophrenia can feel really isolating or really lonely, especially if you think that you may be the only one who's dealing with those sorts of symptoms. So it's kind of designed to be a sort of sense of community where people can come together and really talk about what they're going through. So in terms of what logistically CBSST looks like at Iowa, so it's a group-based format. So James and I will be the facilitators for this year, and there'll be about 4 to 10 members within a group. Logistically, the sessions will take place at the University of Iowa Seashore Psychology Clinic. We have some nice kind of group rooms where we can all get together. Feels kind of cozy in there. It's $5 a session, so it's meant to be that, financially it won't be like a significant burden on people, especially if some people, don't have a job, or financially that can be pretty difficult. We also have a sliding scale available. If even $5 a session is too much, we can always kind of talk and come up with a game plan. We meet hourly for 1 hour a week. And then if people are really excited about this and they really want to engage further, there's the option to meet with me or James individually for individual therapy, also 1 hour a week, to really focus in more on those specific goals and give someone a chance to be a little bit more personal. We assign homework between each session, and that's, again, really just to practice these skills, to get better at them, and to just make it kind of more routine and more a habit. And then overall, it's 18 sessions because each module is 6 weeks. And there's the opportunity for people who go through the first round to do all the modules and all the sessions. If they're interested, they can come back and co-lead with me and James. So it gives people a chance to really kind of get out there and share their personal experience with going through the program, how it may have helped them, and giving feedback on what may be a little bit more successful the second time through, sort of like the NAMI peer-to-peer support groups. And I didn't list it on this slide, but if people are interested and they end up joining CBSST, they also have the opportunity to join one of our research studies at the University of Iowa. So that's separate. It would be something if they wanted to join. And they are different. There's a lot of different paid research studies that we have going on over here. So how to reach us. If you or someone you know if you think they might be a good fit for this group, you can give us a call here. That's our Seashore Clinic phone number. You can also give us an email. We're happy to talk more about maybe would you be a good fit, maybe not, what sort of other things are out there, or give more information about CBSST. And then you can also, if there's people watching this right now, you can scan the QR code and sign up right away. And then James or I will go ahead and give you a call. So I just wanted to say thank you all for listening. And James and I are happy to answer any questions or concerns or feedback you all may have.
This was great. Thank you. It's a wonderful approach.
Yeah, it looks like Angela maybe has a question.
Oh, yes. I wanted to ask, who particularly can join this kind of therapy? Is it more limited to those that experience psychosis or schizophrenia, or is it more general in terms of severe mental illness?
Yeah, right now we're looking to recruit people more with schizophrenia spectrum disorders. Potentially in the future that can broaden a little bit, but that's sort of the main group that we're looking for. Any other comments, feedback? We're interested in, making this really applicable. So any ideas on how to reach people in Iowa City or anything like that would be appreciated.
Yeah, I know we have some information at Our Place Peer Recovery Center. So that's good.
Yes, that's a great place to, I think some folks might be interested in joining.
Yeah, that would be great. And James and I would also be happy to go in person and talk to people at Our Place, sort of like this, but more maybe like informally.
That'd be a great idea.
It would be. Laura and folks would love to have, I think Laura and folks would love to have that.
Yeah.
Mhm.
Someone asked, does insurance cover any costs? So we don't take insurance at our psychology clinic. So it's just the $5 flat or sliding scale.
And that's wonderful. William mentioned he's going to recommend when he's doing mobile crisis support. I think
Yeah.
that's a wonderful
Thank you.
option.
We could send out information when people go in for treatment and when they get maybe like the injectable at UIHC. Yeah, that's a good idea as well.
Mm-hmm.
More people with more options for those who are not wanting to get out to recovery centers.
Yeah, Mary, this is also would be good to mention in NAMI in the lobby when we get there, with people who are family members, with people experience maybe, experiencing maybe their psychotic episode at the hospital. And this is one more reason for hope.
So my comment about more people is that being able to reach more people. I mean, this is another option. Some people isolate themselves a lot and aren't comfortable going to a recovery center. But I think having it available where maybe they come in for the shot, that's a great idea, making it more accessible for them.
Right.
Yeah. Right now we're doing it just in person, but we also hope in the future potentially to have it like via Zoom or online just to reach more people throughout the state of Iowa, just considering, a lot of people live in rural places and might not be able to come to Iowa City. And then another suggestion was to put on the flyer actual outcomes and the value of CBSST, which we don't have right now. So that would actually be, that's a really great idea. All right. Well, I don't want to keep you guys too long.
It works well with Amanda's first episode psychosis work too.
Yeah, so we're hoping, we really want to be able to provide evidence-based interventions across the lifespan. And so, what we hope to do is to modify CBSST so that it's developmentally appropriate early in the illness course as well. So that's something that's coming down the pipeline eventually. But if anyone has ideas for how to sort of reach out to, I'm thinking about sort of psychiatrists in the community who are working with folks maybe in private practice for medication management, like how to get information about this resource to them so that they could also let their clients know. We're open to any and all suggestions. So if there's any sort of community groups or listservs or anything like that, that would be helpful for us to get involved with. Just let us know.
So I'm seeing Abbey Center, which I'm not sure we've reached out to yet, so.
And Liz, maybe we should remind oh, who is it that works at the VA on our board?
Jackie.
Yes, Jackie. We should make sure that Jackie gets this.
Yeah, sounds good.
Although, I don't know if they have to funnel people into a certain program in the VA and not, I don't know how that works.
I think there's plenty of outpatient people that are go to the VA that might be able to afford $5 a session.
Right.
Okay, we can bring that up at the next meeting.
Okay, great. Well, thank you very much, everyone who's joined us, and especially Tess and James. You're doing such great work in our community, and it's so nice to see the work that you're doing and scholarly work that you're doing translate into real action for people suffering. Thank you.
Yeah, thank you all for your attention.
Right.
Thank you, guys.
Thanks, everyone. Come back next month. We're going to be talking about mental health parity. I'm not quite sure, but I think that's what our next topic is.
Mm-hmm.
Thank you.
You.
All right.
Thank you.